Thank you, everyone. I'm going to keep my remarks very brief. First, although I would like to extend a thank you again to Regina for her talk this morning. So if we could all thank her again for coming and sharing her story. It was personal and it was impactful and it was very appreciated. So we appreciate you sharing that with us. My name is Steve Lusky. I work with the Cambia Health Foundation, and we give grants in Oregon and beyond to help transform healthcare, particularly around improving quality, integrating care, and increasing patient activation and engagement through greater transparency. Real quick, I was honored to be here at this conference last year in the audience, listened to the discussion about open notes and the subsequent work that was done to look at what it would take to bring open notes to Oregon and really create a movement. I was impressed with this organization, impressed with the ability and the willingness to bring diverse stakeholders together that might not always agree on everything, might not always agree on the solution, beyond something needs to change. And so I really appreciated that. I listened a lot to the work that was done, what was said about open notes, then subsequently worked for several months with the staff and board of We Can Do Better, and went in front of my board of trustees, and they approved a grant for $100,000 to move open notes forward here in Oregon. Thank you. And that is because of you. That is because of the work that you did and the work that, for example, that you will do after lunch. And so it is meaningful. I appreciate you being here, and things can and will and are going to happen as a result of you being here today. So I'm going to step aside because the lunch is an opportunity to update you on the work that's happening with Open Notes, and I believe it's going to start with a video. So thank you again for being here and all of the great work that you're doing.
My name is Godfrey, and I am a retired teacher, but working part-time teaching reading and enjoying that very, very much. I want to live to be 100. And so I just really feel the best thing to do is to be engaged in some special thing, and I think teaching really fulfills that role very well. I would say my biggest health concern is definitely blood pressure, because I worry about all the consequences, like stroke, heart problems, all those kinds of things, and they do scare me. I love Open Notes for the fact that I can just keep track of everything that's been going on in my health. I want to be a partner. I want to really be on board with my health. I don't want to be in the dark. I don't want to have the doctors have access to things that I don't. I want to know. Open Notes gives me the opportunity to sit back and review what I heard at the doctor's office and to digest it. Even if I call and speak to a nurse, she writes an open note about that. If I forget what was said about the medication, I can go back and see what medication and what the dosage is, and all the things that I'm supposed to know are all recorded in that note.
So I'll update that in the computer.
All right, yes.
And what else?
And the hydrochlorothiazide and metoprolol. Metoprolol.
Ellen has been one of those patients who, when Open Notes started, she definitely joined in. And I think that it added a lot to our relationship first, and then to her health. All right, so let's measure your blood pressure.
With her, I just feel that, she revealed to me through the Open Notes that all the little communications that she puts in there, all the things that she says, that she heard me say, she puts it all down, and it makes it very easy to trust her.
Okay, that sounds good. And I'm going to have you take a few deep breaths.
All right.
Go ahead. Knowing that I was electronically, like a key away, or however you want to think about it, I was just right there. I think that gave her more confidence to manage her hypertension. How about any symptoms when you're doing exercise?
The Open Notes will reveal that, she talked to me about the diet and the food and what an important part exercise has in lowering blood pressure. So it's so wonderful to be able to go back and review what she said. And it just kind of gives you a little shot in the arm to say, I'm, slipping a little bit here, but this is what she said, let me get back on track.
Because I do think it will affect your blood pressure.
Yes.
I think it allowed her to take control over her illness, which is something that is empowering, and it's very important for patients who have chronic disease to feel like they understand what's going on and they know how to slow it down and sort of manage it. So I think in Ellen's case, it was a perfect fit. The more knowledge and tools that she had, the better her condition seemed to be.
I do feel like a healthier person with my open notes. It's about me, and I want to know what's going on with me, and that's the most important thing.
I'm John Santa. I'm a general internist. I'm a medical director at Consumer Reports. I can't tell you how thrilled I am to be back here, because as some of you heard, I was here last year and gave one of the keynote speeches, and I think I spent maybe 10 minutes, 15 minutes on open notes. And from that few minutes has come what you're going to hear about today, because Liz and Amy and We Can Do Better felt like they could get something done when it came to open notes, and they have. So it's incredible to think that hundreds of thousands of patients and consumers in the Northwest are seeing their medical notes today, are able to see their medical notes today from what started a year ago. And I hope that lays the groundwork for the work that you're going to do this afternoon. A few people can have an incredible impact when they put their minds to it. Well, first of all, I want to recognize the folks who really got this done. Amy Fellows and Homer Chin, who are essentially the We Can Do Better staff, have just done a tremendous job. Homer, stand up. Homer, stand up. And Amy. And I know Tom Del Banco and Jan Walker are with us in spirit. I talked to them this morning. They wish they could be here. Really, Tom and Jan are the geniuses that appreciated that now was the moment to strike. And when I say that, let me make sure you understand what Open Notes is. Open Notes is really simple. It's easy access to clinician notes. It enables patients to read and ruminate on what their clinician writes and what their clinician thinks, because many of us think through the notes we write, and to do that when they want to do it and on their terms. It reminds me of how wonderful I felt when I was in Oregon and I started to be able to vote from home. And I could spend as much time as I wanted on the ballot, on my terms, looking at whatever information I wanted to look at. It's that kind of a revolution. Okay? Now, I want to make sure you know, Open Notes is not a software program. We're not selling anything. We're not selling anything. And it's not a regulation. We all have the right to our medical record. Nobody is arguing that anything needs to be done. The problem is getting that medical record and getting it when we want it and how we want it, and being able to see our entire medical record. Tom and Jan, their research really describes the pros and cons, and let me just quickly summarize those for you. The challenge here is to work through these issues with the other partner we all have in our notes, our doctors. About 30% of physicians, in one way or another, are troubled and have some concerns about their notes being shared. But what the research and I think experiences you're going to hear today, these are manageable. They don't occur as frequently as physicians are worried that they will occur, and they can be easily managed. A small portion of patients, between 1% and 8% or so, are confused when they actually read their notes. That's smaller than everybody thought it would be, and again, it's manageable. The most important number for Consumer Reports is that after a year of having access to notes in Tom and Jan's research work, 99% of patients wanted to keep it. They didn't want to lose it. 99%. You can't get better than that. You can't get better than that. And now realize only 80% of those people had actually read a note. The other 20% hadn't read a note, but they wanted to be able to read a note, and they wanted other people to have access to their notes. This opens up, of course, a variety of next stage issues that perhaps we can talk about at the question stage. How are patients going to share their notes? Who are they going to send their notes to? And in fact, Tom often talks about it's only a matter of time before somebody puts up a medical note on their Facebook page. And the whole world sees it. What about those wonderful folks who take care of patients, our parents, our relatives, who they need access to those notes? And what about the patients who say, I'd like to contribute to my note. I'd like to write part of my note because, to tell you the truth, I think I can get it more accurate than you have. From a Consumer Reports point of view, Open Notes is one of the 5 most important advances that we think happened in 2013. And, the first one was the Affordable Care Act and its continued rollout. So we thought that Open Notes really was an incredible advance for consumers. And in a perspective article in JAMA, Jim Guest, our CEO, used some serious language describing what he thought Open Notes should be. And he did it intentionally. And the language he used is he thinks Open Notes should be, has got to be the standard of care. Everybody deserves to have access to their notes. So with that, we're fortunate to have a panel of folks who are living and practicing and doing Open Notes to share with us their experiences. Rob Unitan is a pulmonologist and intensivist from Kaiser Permanente Northwest. He's the Director of Optimization and Innovation. For 20 years, he's been doing great work around quality improvement. Much of this has been focused on really a leading-edge patient support tool that he's played a major role in developing at Kaiser. His work involves the oversight of telemedicine and member-facing technology. He sits on the board of directors of the national organization that Kaiser Permanente has for IT innovation, and has been involved in the Fund for Technology since 2010. He's an advisor to Kaiser Permanente's national work around innovation and advanced technology. He's going to share the Kaiser experience with Open Notes. Tim Burdick is a family physician. He practices at the OHSU Scappoose Clinic. He's, most importantly for this discussion, the Chief Medical Information Officer for OCHIN. OCHIN's this wonderful national network in, I think, 18 states, serves 78 clinics, and basically Tim and OCHIN guide those clinics. I think there's almost 5,000 doctors in those clinics around how they can optimize their health information systems. His career has focused on improving electronic health records. Before he was in Oregon, he played a leadership role at Fletcher Allen Healthcare in Vermont. Those of us on the East Coast, it's like Vermont's like Oregon. It's an incredible place, and he did incredible work there. He worked with 65 clinics there on health information issues. He's been involved in multiple research projects related to electronic health records. And finally, John Greaves is a physician at the Vancouver Clinic. He's been there since 1979, so he's my generation. He's a cardiologist, and he's practiced cardiology for 35 years and still does so. And as you'll hear, during his entire career, he's been doing open notes. Not the movement, not capital O, capital N, but open notes, making his notes accessible easily to patients. He was president of the Oregon affiliate of the American Heart Association in 1989, and on the board of that Oregon affiliate. He's been in the trenches. He directed the cath lab at Southwest Washington for 10 years. He now practices part-time, if there is such a thing, and focuses on outpatient cardiology. So 3 folks who are in the trenches, both taking care of patients and involved in health information. Rob?
And again, I really appreciate the opportunity to be here with you today and to share the experience that we've had with this Open Notes project. We started out talking to our patients about it. We actually went out to the West Side Patient Advisory Council. I think there are a few members of you out in the audience, and they were like, we've wanted this forever. What's up with this? Why can't we see our notes? And it's like, well, of course you can, but it's 73 cents and you'll have to wait, 21 days for it. And so, with that, Dr. Mike McNamara, who succeeded Homer as our Chief Medical Information Officer, really embraced this and took it to our leadership, our primary care leadership, and said, what do you guys think? We didn't go in thinking that we were going to go all in, but there was such incredible support, in part from the region-wide collaboration that we've had with the consortium, the knowledge that all of the medical groups in town essentially are going to be doing this year or next. Together with just the fact that it's just the right thing to do. That our primary care leadership said, not only should we do this, but we shouldn't just pilot this. We should do this, and oh, by the way, our specialty care colleagues should be doing this as well. And so, fast forward a few months, and not a whole lot of IT development. It is not very hard to do in the electronic medical record. One of the nice things about Portland, in addition to being an epic town, is it's an epic town. We've had the good fortune, thanks in part to Dr. Homer Chin, to be Epic's oldest continuous customer. We've had their ambulatory medical record up and running in the Northwest for 20 years now. And we were, again, very fortunate to have the support of our leadership to make this available to all of our members who have active MyChart accounts on kp.org, which is over 2/3 of our adult membership. As of April 8th. So all the notes going forward, and that's about 10,000 notes a day. As soon as that encounter is closed, a tickler goes out to the patient via email and says, you've got a note from your clinician on kp.org, and we provide a little link there, and they click it, and they can go in and read the notes. It's happened to me. It was kind of a wonderful treat to get that email tickler. And I will say, again, it's still early. It's only been, a couple of weeks. But it has largely been a non-event. We do not have clinicians screaming about this. We don't have patients screaming about this. It's gone just like we were told by Tom and Jan from Beth Israel Deaconess how it would go. And so, again, just want to extend my thanks to the entire community for the support for this, because I think it's going to improve the quality of care that we're able to deliver to our patients, especially engaging them as full partners in their care.
Thank you, Rob. I'm Tim Burdick from Ochin, as John Santa introduced me. Ochin has a very different model. Ochin is an organization, nonprofit. We provide an IT support and quality improvement services for healthcare organizations, independent healthcare organizations across the country. We run one instance of the Epic electronic health record across the country, It's shared by 78 independent healthcare organizations in 300 plus clinics in 18 states. So our governance model is completely flipped in that we can provide the electronic tools, we can provide recommendations on how those tools be used, but we can't require that an organization start using open notes. So Kaiser had very, very great leadership that saw the benefit of this and made an organizational decision to turn it on for all of their providers. Ocean has to take a little bit different approach, and we have to sort of nudge individual organizations. So we've worked with Epic organization, and we've created the technology with Epic so that one provider at a time can decide to start doing this. Now, personally, I wouldn't necessarily go about this, but the reality is that open notes is still a somewhat controversial topic in healthcare. So what Ocean's relying on is organizations like We Can Do Better, individuals like yourselves, going out to the community and demanding that patients have access to their notes. If patients walk into the exam rooms and say, boy, at the end of this visit, I'd really like to see my office visit note, can you make that available to me, please? That's going to put pressure on the providers and on the healthcare organizations to start doing that. We've created this technology, the demand needs to come forward along with it, and that's starting to happen regionally as well as across the country, and I think that's going to be a really, really important driving factor for making this. Organizations like Kaiser also doing it and saying this is how we do business in healthcare now. This is just a standard of care. That's also going to push other organizations to start doing that as well. Ocean has about 65% of the Oregon Medicaid population. So it's also a different population. We have a significant uninsured and homeless population as well. The early open notes research, particularly up in Washington, showed that that's a patient population that's very much interested in this as well. Rural populations, urban populations, federally qualified health center populations are interested in this. It doesn't apply to any particular group of patients. It cuts across, as we saw in the video, older patients and younger patients. And so at Ocean, we've made a decision to move forward with this, and now we hope that the demand will come forward as well.
Tim, thank you very much. My name is John Greaves, and I've been in the practice of cardiovascular disease for 35 years at the Vancouver Clinic. And when I joined the clinic, we were an organization with 27 doctors, and we're now passing 230 providers or so, and have grown with the community. And through that entire time, I'm assuming I was asked to be on this panel because I have stood in many meetings and talked about the fact that the medical record really belongs to the patient. The patient is the owner of the medical record. And in this day and age, that's becoming much more open and much more a part of this entire movement. But I can tell you in 1990 and in 1985, that was kind of a unique approach to interacting with patients. And I want to just build on what Rob and Tim have said about the openness of what communication means with patients, the openness of what it means to be part of a team interacting together with patients and getting patients on board. And it is all developed around communication, communication, communication. So I have always looked upon myself as a healthcare advisor. I am there to interpret cardiovascular science for patients, help them to understand what we know in cardiology based on randomized, controlled, evidence-based medicine, and what is, in part, John Greaves' belief system based on the practice of cardiology. And believe me, there is still, in medicine, a tremendous art to it, and there is a tremendous belief system based on physicians and how they interact with patients. Because I can give you an excellent example of that. There is an advisory group within the United States that advises physicians on the guidelines for the treatment of hypertension. And this has met since the mid-1980s. And we were ready for what we call JNC 8. So that's the name of the group, is JNC, the Joint National Commission on Management of Hypertension. And the JNC 8 guidelines didn't come out in a timely fashion, and in fact, they got labeled as JNC late. Everybody was saying, where in the world are these guidelines that we're supposed to be using for the treatment of our patients in managing hypertension? And it's because when they just came out and were published in JAMA in the last 8 weeks, it is so difficult, based on the evidence that we have, to make declaratory statements as to exactly how this is to be done. It is still very much science-based, but a huge interpretive interaction between you and your patient and what you're trying to accomplish. So I have been selected as part of the Open Notes movement at the Vancouver Clinic. We will be ready for our rollout within the next 6 weeks. And it's exactly as Dr. Santos mentioned. There are a number of physicians who are uneasy with it, or providers who are uneasy with it, but I think we'll go right past that. I think it's clearly the right thing to do. We have to get America involved in their health, and we have to become a healthier population all the way around. I think that modern medicine will have done its job when there is no longer any need for we can do better. And that's kind of where we all need to be, and that is where we need to be thinking, because this whole concept that there is somewhere an adversarial relationship between patients and medicine and how medicine is used to heal you and to heal your family is a concept that has to go away. I mean, this cannot be about systems that are not on the patient's side. This is all about systems that are developed with the patient and for the patient, and should be the really icebreakers through the ice to get the kind of healing done that needs to be done for them. Thanks.
Okay, yeah. So, just to give you some context, basically, I think there's 9 health systems or major medical groups now in the Portland metropolitan area that are pursuing Open Notes. The VA already was at Open Notes. We have Ocean, we have Kaiser, we have the Vancouver Clinic, we have the Portland Clinic. The Providence system will go to the Open Notes approach in 2015. Maybe a few of you who are involved at Providence could see if you could hurry that along. Legacy actually has some individual physicians on Open Notes as I speak, and is hoping to get their first group up in July. OHSU has some individual physicians and some groups. Tim's clinic, for example, at Scappoose is up on Open Notes. The folks in Salem at Salem Health, the Salem Hospital medical groups are implementing Open Notes currently in a medical group in Salem. And we're very interested. The next stage, our working group that Homer chairs and Amy helps with, we're going to be talking to other systems in Oregon and Corvallis and Eugene and everywhere else, and trying to move them in the same direction in the coming months. So are there questions, comments?
Okay, I'm just curious if anyone on the panel could speak to what is being done to ensure access to open notes for individuals that may not have access to a computer or the internet or a smartphone or any of these things, and especially not only in the city where I see a lot of my students waiting, an hour, 2 hours in line for a half an hour on a computer at the library, but also when you go more rural, how is that going to work for all individuals?
That's a tough one. There are some areas that are trying to push the technology out to smartphones and tablets. Epic EHR system does have a free app for both of those platforms and for Android that will allow people to use it that way. Public libraries is probably the other place. The original research study with the folks up in Washington, the homeless population was going to the local public libraries. I would encourage organizations out in the communities to start working with the public libraries and training the librarians, particularly the librarians that are assigned to work with the computer systems, to understand what Open Notes is, to know in your community which healthcare systems are using that, what the web pages are for those, bookmarking those, perhaps even training those people to help patients sign up for their patient portal. So that's a community system that you can use to help those patients along, but otherwise it's very, very challenging.
I think if Tom were here, he would want to emphasize that Harborview in Seattle was part of the original research group. The results from Harborview were very similar to the results at Beth Israel and at Geisinger. Their sense was low-income patients at Harborview were going to libraries and friends, and they were finding access to their notes.
I think the other thing that's important to keep in mind is that Open Notes is a lot more about communication and delivery than it is just the reading of the physical note itself. So there are all sorts of examinations, lab data that can be printed off, and you can always, I have never been offended when a patient says to me, "Doctor, can I have a copy of the note?" And we copy the note and give it to them. So I think it's really important for everybody to realize that it's not just the physical reading of the note. It is an entire concept of how a physician and patient interacts and how that communication flow goes.
Okay. Go ahead.
As a segue, are you done?
Yeah, go ahead.
Okay. As a segue to that question, one of my primary interests over the past 2+ years has been data privacy. I went to a patient privacy rights conference last June, learned extensively about a lot of things, and that happened to be the week that Verizon had its first Guardian article. I had appointments with Wyden and Merkley afterwards, and of course then Sunday that day I saw in the news Edward Snowden's revelations. So big data nothing is foolproof when it comes to the kinds of information that we are confidentially sending over the internet. In fact, on March 27th, we found, my husband and I, that we are victims of taxpayer identity theft. Somebody got our Social Security number. So e-filing, got a race with those imposters. So as I think about access to this sensitive data, and I desperately would love to see this, I'm very, very worried that we have the cart well ahead of the horse on this one. And I want to know what is being done to safeguard this, first of all, and secondly, to address the issues of portability, because regardless of whether or not you have access to your doctor's notes, the realities is in this day and age, we are seeing people move from one insurance company to another, and that's another big issue. So,
Right. Rob, Tim, one of you want to respond to that?
Yeah, so taking the last one first, the issue of portability is a good one. We are currently struggling with that, trying to figure out how long after somebody terminates their membership can they continue to have access to at least the full functionality that's available on our MyChart portal, which is called kp.org. And so that is something that we're having to struggle with, because individuals can use that to do all manner of things in terms of, getting refill their prescriptions and, email their doctors and whatnot. And once that relationship is essentially terminated, access to the notes becomes a more difficult issue. With respect to the privacy, we take that very seriously at Kaiser Permanente, and understand that once these notes are outside our firewall and are on, personal devices out in the community, there's not much that we can do at that point to protect them. It's up to each individual to protect, their own information. We are certainly not aggregating this information or making it available to any third parties. This is only available to the individual patient or anyone that they have designated as their proxy. So a caregiver, for example, who's already been designated would be able to have access to it, but that's how that's limited.
Similarly, OCHA, I think probably could speak for most health organizations, the privacy security issue is front and center, and the issue of patient portals, in addition to open notes in general, is evolving rapidly and being closely scrutinized. In almost all of the systems, the information that's being viewed by the patient in their patient portal is not downloaded to the device that they're viewing it on. The data itself remains behind the healthcare system's firewall, and it's viewed on your tablet or your phone or your computer, but not unless you explicitly take an extra step to download it. It does not go to your device. So that's a big step. If the patient individually chooses to download it to that device, they have to make a conscious decision to do that. And then beyond that, it's really up to them as to what they choose to do with that.
So this is for Dr. Unitan. It's actually two small questions, perhaps. So, first of all, when you rolled out the program at Kaiser, was there a learning curve for doctors, or most of them pretty much assumed that their notes were available and therefore they just didn't have to change their notes? And the second question is, the open notes is not for all doctors' notes. I mean, I think we talked about that yesterday. I mean, you said that there are like mental health and perhaps sexually active teenagers. There are certain issues, certain places where you don't have open notes. So could you expand on where and what the rationale for those situations where you don't want to have open notes?
Yeah, those are... Oh, got it. Okay. So taking the first question, we did go out, and actually I want to give a shout out to Monica Seidel, who is our program manager for this. She's here in the audience as well. Went out to a number of large department meetings to make sure the clinicians knew this was coming. We also made sure that only notes from April 8th going forward were released or were going to be viewable via the kp.org portal, because we didn't want sensitive information that might have been put in the chart shared in this manner. We also had some, helpful tips and tricks, some useful do's and don'ts. You can imagine that the, medical abbreviation SOB for shortness of breath could be misinterpreted by some folks. And so we did encourage clinicians to use the tools that are available within Epic to kind of help them with that so that they didn't slip up on that. And regarding the latter question, most of the organizations that went live with Open Notes did exclude and have still excluded mental health notes, specifically the psychiatrist notes. And that's a little controversial because, as most of the folks in the audience know, most mental health is done in primary care. Most of the people who have anxiety and depression are getting that care from their PCP. And yet we know that psychiatrists take care of a different slice of the population, and so they have been excluded, along with addiction medicine, pain clinic, our employee health, our own employees, and then also occupational medicine. You mentioned the teens, and we do exclude this for teens aged 13 to 17. Their notes are not available because of the sensitivity around both, sexuality, drug use, whatnot, and so because they're in a vulnerable position where their parents could potentially have access, we very intentionally don't share that. And then when they become 18, they can then choose who they want to share with. But that's how we've handled it. And again, so far it's gone very, very well. We also have the opportunity for a physician to hide an individual note. So if a clinician is having a sensitive conversation with somebody, and just that one time they want that note excluded, there is an easy way that they can actually suppress sharing of that note. It could be a request that would come from a patient. You can imagine a woman who might be in a situation where there's domestic violence, not wanting her husband to see that she had mentioned that to her provider. We wanted clinicians to be able to have that. What we're finding is less than 1% of all the notes are being hidden, and this is after making it clear to all the clinicians how to do this if they need to. And furthermore, it's a handful of clinicians who are hiding the majority of the notes. So there are, again, a very small minority, I would say less than 1/3% of our clinicians who are effectively trying to opt out by clicking hide note every time. Everyone else is pretty much all in. So thank you for that good question, Lee.
Let me just close with, really, Oregon and Southwest Washington are the center of the implementation of open notes. There's just incredible stuff going on here, and the rest of the country is, I think, fascinated and intrigued with what's happening. I would emphasize that we're talking about ambulatory notes here. But if you were at Johns Hopkins today and a family member of yours was in one of their ICUs there, a team of people led by Peter Pronovost would give you an iPad. And the iPad would have access to everything going on in the ICU, to the same dashboard that the ICU physicians were seeing. So you would know everything that was happening to your family member at the same time the physicians managing your patient would. So there's incredible things to come. So just urge you all to think about how you can help us, and we're going to keep working at this and really appreciate your support. Thanks.